by using your name, first and last, and then the event ID number. So that is 44154. The link is here as well, but that's also included in the team's invite. So along with a job aid on how to claim your credits. Just a reminder, you can claim those credits only in the first 30 days after this meeting. After that, you won't be able to claim those. So please make sure you do that as soon as possible. For everybody on the line, if you can mute your lines so that way we don't get any echo for Dr. Rangadhama as she's presenting. And I think then, Kathy, is there anything else from the CME piece that we need to go over?
No, they just we did attach the job aid to this meeting request. So if they want to go in and pull the link from there, I think you did say that, and then all they need is the event ID number. We do need their credentials on our attendee list. So if they could chat us their credentials, that would be appreciative. And I think we're good.
All right, great. So I'm going to introduce Dr. Rangadhama. She received her medical degree from MS Ramaiah Medical College in India. She completed her residency in obstetrics and gynecology at Jamaica Hospital Medical Center in New York, where she also served as chief resident for a year. She completed fellowship training in a minimally invasive gynecologic surgery program at St. Elizabeth Medical Center in Utica, New York, and has been practicing since 2014. Dr. Rangadhama is a member of the American Congress of Obstetricians and Gynecologists, and she's fluent in English, Hindi, and Kannada. Dr. Rangadhama is currently seeing patients at Nazareth Red Lion Road Women's Center, and she is part of the St. Mary Medical Center OBGYN practice group. So with that said, Dr. Rangadhama, I'm going to turn the meeting over to you.
Thank you.
Okay.
Hello, everyone.
It might be how we're doing.
So I will be presenting today fibroid, that's like the leiomyoma, commonly called as the fibroid. So it's like the most common like solid benign neoplasm in the woman. It accounts for almost like 70% by the time like woman reaches like menopause. So most of them are like asymptomatic. Only like 25% like require any like intervention, because most almost like 50% like they won't present with any symptoms. The uterine fibroids, it's composed of like the smooth muscle cells and the fibroblasts. The chances of turning into like cancer is like only 1%. That is like leiomyosarcoma. So 99% are benign. So the types of the uterine fibroids, it is depending on the location. It can be like segregated as intramural if it is in the muscle layer, subserosal if it is like close to the surface of the uterus, and submucosal when it is close to the lining of the uterus. So out of these three, the intramural and the submucosal are like more symptomatic, causing the bleeding symptoms, and subserosal are like not that much symptomatic. Only it causes the bulk symptoms only if it is too big. But submucosal, even though like it is like 1 centimeter, the small one can still present as like heavy bleeding. On the other hand, subserosal like to present as like kind of like symptoms, it will be like kind of like more than 5-6 centimeter. So this is the pictured description of like the fibroids which I went through. So this is like the lining of the uterus. This is submucosal fibroid, which has like the component of the intramuscular also. And this is like close to the lining, subserosal. This is predominantly like subserosal. And this one is the submucosal with a pedunculated submucosal fibroid. And the International Federation of Gynecology and Obstetrics, they classify the fibroid in 8 different types. It's more or less the concept is still the same. So, but they go depending on like how depth of involvement with the intramuscular or the submucosal or subserosal. So 0 to 3, it's almost like submucous. 0 being like completely like a pedunculated submucosal fibroid, and 3 is just like touching the surface of the submucosal, but 100% is like intramuscular. And 2 to 5 comes to the intramuscular component of the fibroid. And when you're talking about like above 5, like these are all like the subserosal fibroid. 7 is the pedunculated subserosal, and 8 one, it is either the cervical fibroid or the other part of the parasitic fibroid. Sometimes like this can get attached to the bowel or like the nearby organs, and that is classified as a 8. So for us, like this one is more or less is good enough compared to in depth of this much, like making it more confusing. So the fibroid is one of the structural cause of like causing the heavy periods. When it comes to the abnormal uterine bleeding, we classify these four kind of like pertain to the structural causes, and these are hormonal causes. The structural causes are like polyp, adenomyosis, that is the muscle wall thickness of the uterus, leiomyoma, nothing but like fibroid, malignancy or the hyperplasia. And the hormonal causes comes down to coagulopathy, ovulatory like dysfunction, endometrial and iatrogenic. So this is how like we look the fibroid when we go intraoperative. This is the uterus, the tubes, ovary, and this huge thing like you're seeing is the fibroid. And on the ultrasound, it looks this way. This is the uterus, and this thing like hyperechogenic thing is like myoma. It's nothing but the fibroid. So the factors which are increased, associated with the increased risk of like the fibroid, it increases with the age because almost like 70% like happens like by the time they reach the menopause. It usually presents in more so like in the late 30s, 40s. And the premenopausal status is associated with like the fibroid. Family history, like when it comes to family history, like basically like you can see the fibroid in 20s itself, and increased interval since the last childbirth, obesity, hypertension, and also the ethnicity. It is more common in the black woman compared to the white woman. It's almost like 3 times more in the black woman. And which decreases like the incidence of the uterine leiomyomas are the increased parity, because the more um, the childbirth, like the basically like it decreases the incidence. And also any hormonal contraceptives like Depo-Provera, that also like will decrease the incidence of the fibroid. And the symptoms mainly like depends on the location, size, and the number. Apart in this one, like the location plays a like very important role. Submucosal and the intramural causes more symptoms compared to the subserosal fibroids. And also the size plays a very big role. In the intramural and the subserosal, only the bigger fibroids will be like more symptomatic, and also the number of fibroids. And the symptoms, you all know, like it causes the like the in the heavy periods. That's one of the like the most common like the symptom of the like the fibroid. Painful period like the dysmenorrhea, and dyspareunia, that's a painful sex. Pelvic pressure, these are the bulk symptoms. And enlargement of the like the lower abdomen, low back pain, urinary frequency, constipation. And these three are the last three are the like the bulk symptoms, depending on the like the size of the like the fibroid. And lastly, like it also can cause the like the complications during the like the pregnancy and labor, like preterm labor, and also sometimes like obstructed labor, and like increased chance of like the C-section. And the diagnosis mainly like by the history and physical examination. And sometimes we need the like the imaging modalities like pelvic ultrasound, most common, and very rarely like we use the like the last two one, like the sonohysterogram and MRI. The treatment, so there are three basically like expected treatment, medical and surgical. So if the patient if the patient is asymptomatic, not causing any like kind of like the bleeding symptoms or the bulky symptoms, and if they want to observe, like that's completely fine with that, like expectant management. And the other two are the like the medical and the surgical. Medical treatment. So we have the like the gonadotropin like agonists, that is the, like the GnRH agonist with or without the had-back hormonal therapy, and the GnRH antagonist, and then the selective progesterone receptor modulators. This one, the third one, is still not FDA approved in the USA. Like it is approved in the like the European countries, but not in the US. And this one, like everybody knows, has a like Marina IUD. And we have a, like the newer one, like Liletta, also like the progesterone IUDs, which helps with like the bleeding symptoms for the like the fibroid. And we can also use the like the contraceptive pills, either the combined, both the estrogen and the progesterone combination, or the like the progesterone only pills, but they are like less effective compared to the like the hormonal IUDs. And this one, like the tranexamic acid, it's a antifibrinolytic medication that prevents the like the fibrin degradation, that can help to like reduce the like the bleeding. Usually like we will give like it comes in the 650 milligram. We will give like 2 tablets daily, 3 times a day. Like that helps for the, like the bleeding. So some are used for the like the long-term therapy, like this medical treatment, and some are used for only the like the to bridge either for the like the surgery or the like the menopause. In those instances, we will come under like the GnRH agonist and antagonist. We use only for the like the bridge therapy. The GnRH agonists are the like the Lupron, GnRH antagonists. This comes in the like the oral medication now, and the new one which is like released as like Orion, that is a elagolix with like the hormonal add-back therapy. So the Lupron, it is used only for the bridge therapy because basically like once you stop the treatment, in 3 to 9 months, the fibroid will come back to like kind of like it's a pre-treatment. That's why like it is used only for the like the bridge therapy, either right before the surgery, like to increase the like the hemoglobin, or like when you are bridging when they are like very close to like perimenopause, like menopause. If you are like just buying the time, like just like few months or like a year or two, like you can use that treatment. And the IUD, you can use it for like almost like, because it is good for like 6 years. But only drawback is like with the, like the fibroids that can distort the like the cavity of the like the uterus. So the expulsion rate of the like the IUD is more, almost like 11% compared to like 0 to 3% in the like the non-fibroid patients. Now we will go like in detail with each one. So as we went over, so the GnRH agonist, like we usually like use in combination with like a had-back hormonal therapy to prevent like the menopausal symptoms which comes with like the GnRH agonist. These are like kind of like the menopausal symptoms like hot flashes, unfavorable like lipid profile changes, like increased in the LDL, decrease in the HDL, and also decrease in the like the bone density, causing the like the increased risk for the osteoporosis. So as we mentioned earlier, like this group is usually used for the like the only to bridge the like the treatment, because once we stop this treatment within 3 to 9 months, like the leiomyoma will regrow back to its original the size. And also we use like sometimes like when we are like buying the time like right before the like the surgery, because this Lupron will decrease the like the size of the like the fibroid and also will increase the hemoglobin right before the like the surgery on an average like zero 0.8 milligram, zero 0.8 gram, like that's almost like a 1 gram of like hemoglobin is like increased because it decreases the, like the bleeding. And Lupron comes in like a two ways, like either you can give like monthly, that is 3.375 milligram intramuscular injections, or like 3 monthly, that is 11 milligram like in 3 months duration. It usually induces the like the hypogonadism, which causes the reduction in the like the bleeding and also will result in the like the amenorrhea. So it is limited to like only like 6 months if you are not using the like the had back therapy, not using the like the hormonal therapy, and you can use up to 12 months if you are using in combination with like the had back therapy. That is the like the conjugated estrogen like 0.625 milligram, and then the like the norethindrone 5 milligram daily. And the second group is the like the GnRH antagonist. This is like kind of like the newer one compared to the like the previous one, like the GnRH agonist. And in this one, like they came with like the oral the pills instead of like the injections, and the name is elagolix, and the like the brand name like which is coming like recently is Orion. That is the elagolix, the 300 milligram BID with a combination of like 1 milligram estradiol and 0.5 milligram norethindrone, which helps for the like the to prevent the like the menopausal symptoms, and also to decrease the like the adverse like the lipid profile, and also like to prevent the like the osteoporosis. This is FDA approved to use for almost like 2 years for the like the abnormal uterine bleeding associated with like the leiomyoma. The next one is the like the hormonal IUD. We have like two of them, like Marina and Liletta. So Marina is approved, Liletta is still in the like the process, but that also contains the like the same thing, the 52 milligram of Levonorgestrel IUD. This is used for the like the treatment of the like the abnormal uterine bleeding associated with the leiomyoma. Um, they did the like the prospective like non-randomized study of like 67 patients, and they found like the significant reduction in the like the blood loss within 3 months of insertion. And by 1 year, it achieved like 40% of like amenorrhea, and 95% of the patients had a, like the anemia completely like resolved from the time of insertion. So it decreases the like the bleeding by inducing the like the endometrial deserialization and atrophy. It basically makes the like the lining very thin. So initially like they will be having irregular spotting for the first 2-3 months. After 3 months, like it decreases, it spaces out, and after 6 months, most of the time they won't be having the like the bleeding. The only thing with like the fibroid, you have to be like kind of like warn the patient, because there is an increased expulsion rate, because that will distort the like the cavity. It's almost like 11% increased in the like the expulsion of the like the fibro of the like the IUD when it compares to like 0 to 3% in the like the non-fibroid patients. So this is another like hormonal modality of treating the like the fibroids. The selective progesterone receptor modulator, ulipristal. So this was used for as like the plan B, but it is still not approved in the USA like for the treatment of the like the fibroid. They are used in the like the European countries, and they are still like very cautious in using this medication because of the like the rare and serious like liver injury. Some require the like the liver transplantation like with this use. And the last resort when it comes to like the procedure and the, like the surgery, so the uterine artery embolization, radiofrequency ablation, focused ultrasound, or the MRI like ultrasound. These two will causes the like the uterine like fibroid like necrosis. um, Endometrial ablation will decrease the, like the bleeding. myomectomy, and the hysterectomy. So for these three, we kind of refer to the uterine artery embolization, radiofrequency ablation, and the ultrasound, focused ultrasound. We refer to the interventional radiologist, and we have an interventional radiologist at the Nazareth, Dr. Filston. Um, so he can help with the uterine artery embolization, that will decrease the fibroid size and also the bulk symptoms, and help with the bleeding symptoms, and it is good for almost for 5 years. And if they fail, then we can go with the surgical management like myomectomy and the hysterectomy. Some patients who do not want to have the surgery, we can discuss these options. So this is how the uterine artery embolization is performed. So from the femoral vein, basically they will reach both the side of the uterine artery, and that will kind of block the blood supply to the fibroid, causing the uterine fibroid necrosis, and that will decrease the size of the fibroid and also the bleeding symptoms. And this is recommended for the patients who desire to keep the uterus, and they are counseled about the limited available data for the reproductive outcomes. So we are not sure because once we block the uterine blood supply with the future pregnancies, still we don't have any particular the data with the future pregnancy outcomes and all those stuff. Definitely we do not recommend for the patients who desire to keep the uterus for to have future pregnancies. In those instances, we will go with the myomectomy, taking the fibroid out. This is some information regarding the radiofrequency ablation. Currently, the FDA is approved only with the laparoscopic approach of the radiofrequency ablation. There are other modalities like the transvaginal cervical approach using the ultrasound guidance to induce the coagulative necrosis to the targeted uterine leiomyomas. And the next modality it's the newer one, focused ultrasound surgery. So basically either the diagnostic ultrasound or the MRI is the non-invasive treatment. It uses the multiple high intensity ultrasound waves to cause the coagulative necrosis of the uterine fibroids. Currently, only the MRI guided focused ultrasound is FDA approved. And small randomized study was done, and it suggests that compared to the uterine artery embolization, MRI guided focused ultrasound is associated with a less improvement in the symptoms and high risk of the reintervention. So when you compare between these and the uterine artery embolization is better. And this is the endometrial ablation. It's basically the fan shape, the radio frequency, the is deployed inside the uterine cavity, and this will burn the lining of the uterus, and that decreases the bleeding symptoms. This can also be used for the abnormal uterine bleeding associated with the fibroids. Only thing is we have to be careful because we have to make sure this can be the deployed inside the uterine cavity. If it is a huge fibroid which is obstructing the distorting the cavity, we won't be able to open up this fan, and then we won't be able to do the surgery, because to deploy we need minimal width of 3.5 centimeter. This one able to open up. So if we don't have that much space inside, then we won't be able to do this one. And this also showed almost it decreases the bleeding for almost 5 years. When we are buying the time, when there are the small fibroids, intramuscular fibroids, not distorting the cavity, then you can consider this also as a treatment option. When they do not want to have a kind of the laparotomy, or when they want to preserve the uterus, and failed the hormonal treatment or the IUD, you can consider this also as another option of the treatment of the fibroid. And the last two are the surgical option. So myomectomy is like removal of the fibroid. So these are the approaches of the removal of the fibroid. Hysteroscopic. Um, so when it is like close to the lining of the uterus, yes, it can be removed. It's a same day surgery. Like it takes like half an hour to 45 minutes, and that will take care of the bleeding problems. The laparoscopic myomectomy or the robotic myomectomy, these are the minimally invasive. All three are minimally invasive. Laparotomy is like we consider as like the last resort. Um, when it comes to like the laparoscopic robotic is myomectomy, we prefer to have like the MRI mapping to make sure like the exact location of the fibroids before the surgery. And sometimes before the myomectomy, you can use the bridge treatment. In that way, like it will decrease the blood loss and also helps with the increasing in the hemoglobin. We might consider them like giving the iron pills. In that way, by the time the patient presents for the surgery, at least the hemoglobin is like the boosted, because they are like very high risk for the bleeding, and the blood transfusion rate increases when it comes to the myomectomy. And sometimes we use the diluted vasopressin um, during the surgery, so that that will decrease the blood loss during the myomectomy. And the last resort comes down to the hysterectomy, either the total or supracervical hysterectomy. It's a definitive surgical management for the treatment of the abnormal uterine bleeding associated with the leiomyoma, and also it helps for the bulk symptoms associated with the uterine leiomyoma, because it is pressing on the surrounding organs like the bladder, causing the increased urinary frequency and all the other symptoms the uterine fibroid can also cause the degeneration and the pain that can not be relieved with the hormonal treatment. So this is used only for the patients who desire who do not desire any childbearing, because we are taking the uterus out. So the first laparoscopic and the robotic are the minimally invasive, and also the vaginal hysterectomy and laparoscopic assisted vaginal hysterectomy are the minimally invasive approach. And the last one is the laparotomy, open surgery. We always try to kind of give the option of minimally invasive option. In that way, the patient can go home, um, faster recovery, the lesser hospital stay, and lesser need of the opioid medications, and faster recovery for them, and they can get back to the work, and also the cosmetic reason. So these are the treatment options of the fibroid, and I don't have any conflict of interest, and no financial interest.
Great. Thanks, Dr. Rangadhama. That was great, informative presentation. So I'll open up to any of the providers that are on the line if you have any questions. And like Kathy said, if you can just shoot us a text or a chat message with your credentials, just so we know who everyone is on the line, so we can make sure you get credit for the CME course. And once again, the CME ID is 44154. You have 30 days to claim your CME credit, and you will need your name, first and last name, and then also in the Teams invite, there's a job aid for how to get into the program to collect your credit, with the link as well. And does anybody have any questions? All right, so there's one question, Dr. Rangadhama. Who is a good candidate for non-surgical treatment for fibroids?
So Basically, like non-surgical treatment, like if the patients do not want to undergo the like the surgery, and also when they are like perimenopausal, like in the like the late 40s, um, we would consider the like the non-surgical treatment, because like we are trying to bridge them with the like the hormonal treatments. Um, so because like the fibroids won't grow like after the like the menopause, so we are trying to like just buy time, like only when we are like trying to buy like only like couple of months or couple of years. So they are the like the better candidates for the like the non-surgical treatment. When it comes to like non-surgical treatment, like either you can go with like the medical option. Let me pull up like that slide. So either you can go with like the medical options, either the like the Lupron injections, like which can be used only for like 1 year, or the like the other pill which is like the recent one which can be used for like 2 years, the Elagolix. Um, or like you can do the like the IUD which can be done for like almost like 6 years, like before the, if that works. I know there is a like higher risk of like the expulsion with this, but if it works, then that's also like a really good choice for the like the non-surgical treatment. And when we are considering this hormonal treatment options, you have to be very careful, because the same contra indication will apply like any hormonal. If they are like having the hypertension, smoking after like the age of like 35, they are not like candidates for the like the hormonal treatment, because that increases the risk of like thromboembolism. If they have any heart patients, like they are not a good candidates for the like the hormonal treatment. um, just the same old like the contraceptive pills can also be used for the like the medical treatment. The tranexamic acid is also used for the like the non-surgical treatment. um, and the uterine artery embolization, this definitely is one of the like the next go when the like the hormonal medications won't help, like we will go with like the next one, like uterine artery embolization, because this reduces like the size of the like the uterus and the like the bleeding symptoms. If this is also like not working, like yes, like the next one comes down to like the surgical management, either the fibroid removal or the hysterectomy. Is that answered your question, Nicole?
Yep, it does. So with the uterine artery embolization, is it always successful? Or are there, like if there's still a little bit of blood supply from maybe like collaterals or something that formed, it does it continue to grow then? Or, like is that like 100% fix?
It is not 100% fixed. Um, so basically, like it gives like almost like 50% like decrease in the like the blood supply. Um, there is like if almost like they have like done the like the study. I will pull up that the article that's like the presented in the like the ACOG. Give me 1 second.
I just wondered, we in my past, like IR was doing the cases and they would just come to
Yeah.
recovery to recover. So I didn't have a lot of interaction with this procedure, but I just wondered if it was, uh, a permanent fix and then there wasn't any other issues in the patient's future, or if it just really shrank it in size and then started to eliminate any of the, issues that brought them to you to begin with. So just was wondering.
So they have like this is the like the article which is like presented in the like the ACOG. So they say like kind of like the rate of like reintervention. Like the reintervention you're talking about, like after this like embolization, the patient like the symptoms which are not resolved and they are like going forward again with like either like repeat embolization or like kind of like the surgical option, is almost like 19 to 38%. Um, within like 2 to 5 years. Um, so basically, like they say, like 15%, like in 5 years, will go back, like either like either the myomectomy or the hysterectomy after this the procedure. But if it works, then in that way, there is no surgery risks, kind of they are still preserving the uterus. It will decrease the fibroid size, and it will also decrease the bleeding symptoms. And it is good for 2 to 5 years. When you're talking about in late 40s, so if they do not want to have the surgery, yes, we can definitely say they can go for the embolization. That will shrink the fibroid and also will decrease the bleeding. If it works, that's a great. If it doesn't work, then we have to go with the surgical management. And this is the article which gives the in depth of that particular uterine artery embolization.
Okay. All right. Thank you. Anybody else have any questions? All right. Well, once again, thank you, Dr. Rangadhama, for your presentation. It was very thorough and interesting review. And thank you, everyone that's on the line, for joining us, and hope you have a great weekend.
Thank you, everyone. Have a nice weekend.
Bye.